Hello, my name is Bethany Spencer, and my project is titled Obesity in Low-Income Appalachia, Altering High-Calorie, Nutrient-Deficient, Ultra-Processed Food Diets. The health outcome is obesity, and my priority population will consist of adults, age groups 30 to 50, in low-income rural areas of the Appalachian region. The modifiable behavior to be discussed is decreased consumption of foods high in fat and sodium content, then replaced with fresh, healthier alternatives. Obesity is a chronic condition that is characterized by excessive body fat that can negatively impact an individual's health. From August of 2021 through August of 2023, the CDC estimated the prevalence of obesity in U.S. adults was 40.3%. The table here demonstrates a breakdown of obesity rates by sex and age. Behavioral risk factors include limited physical activity, poor nutrition and food access, lack of health education and resources, cultural attitudes and beliefs, economic barriers, substance use and mental health challenges, and limited access to preventive health care. Rural, low-income areas may lack accessible recreational spaces, public transportation, or fitness facilities, which can limit opportunities for physical activity. These regions often have fewer grocery stores, and residents may rely more on convenience stores or fast food, which tends to offer high-calorie, less nutritious options. People in rural areas may have less access to health education and resources, causing a lack of awareness about healthy eating, physical activity, and weight management. You may see cultural attitudes that normalize heavier body types or a preference for larger portions of food. This can reinforce unhealthy eating habits, and while there might be some acceptance of larger body types, there could also be a stigma, making it harder for individuals to engage in health programs related to weight management. Rural populations may have lower income, making it hard to afford healthy foods or gym memberships. This can contribute to poor dietary habits and limited access to weight loss programs or healthcare services. Smoking and excessive alcohol consumption are associated with higher risk of obesity and other health issues. These behaviors can disrupt sleep patterns and increase the likelihood of overeating. Depression, anxiety, and other mental health issues also exist in rural areas due to geographical isolation, financial stress, and lack of mental health resources. These conditions can lead to emotional eating and poor dietary choices. People in rural areas may visit doctors less frequently due to distance, cost, or lack of healthcare providers. This means they may not receive regular screenings or health advice that could help them manage or prevent obesity. Overall, the combination of behavioral risk factors make obesity more common in rural low-income areas like Appalachia. Addressing these issues requires meaningful changes in healthcare access, education, infrastructure, and community support to promote healthier lifestyles. On the other side, behavioral protective factors include having a healthy network of social and familial support, home gardening options and support of local farming, educational and community-based programs, and preparing regional meals in healthier ways. The social determinants of health affecting this behavior and population include low income, food insecurity, and food deserts, showing access to healthy food options is limited in isolated low-income rural Appalachia. Cultural norms and traditions. Appalachia is steeped in cultural traditions that center around meals that consist of high-fat, calorie-dense foods. Health literacy and lack of education. Health literacy and educational resources are not always available. Geographical and transportation barriers. Rural areas of Appalachia are hard to get to and do not have the infrastructure needed to allow for public transportation, larger retail stores, and importing of fresh whole foods. Healthcare access is also limited due to geographical and other financial concerns. Family and peer influence is a major factor in rural low-income Appalachia. There are tight-knit family units and social circles where influence trickles down from one generation to the next. First, we will look at etiology and address the theory of planned behavior and the social ecological model. The theory of planned behavior states that behavior is directed by one's attitude toward the behavior in question, the perceived social pressure to perform that behavior, and the ease with which one can perform the behavior. The study analyzed addressed two of these three constructs by looking at the attitudes of Appalachian versus non-Appalachians and measuring self-efficacy among survey respondents. The level of self-efficacy would then indirectly influence the respondent's intention to perform a health behavior. The socio-demographic includes geography, sex, race, ethnicity, education, annual household income per year, and body mass index was also calculated. A body mass index of 30 kilograms per meter squared would be considered obese. This study revealed that Appalachians were less likely than non-Appalachians to believe that health behaviors determine obesity risk, which aligns with the measured levels of self-efficacy. So, the theory of planned behavior offers a way to understand the complex factors that influence nutritional decisions leading to obesity. This study in particular highlights the role of attitudes and perceived behavioral control through self-efficacy. Lack of knowledge and skills leading to decreased levels of intention, interventions aimed at promoting healthier eating habits and reducing obesity could address these factors by changing attitudes and improving perceptions of control over food choices. Next, the social ecological model helps to understand various levels of influence that affect behaviors and outcomes, including poor nutritional choices leading to obesity in rural communities like Appalachia. This model emphasizes that behaviors are influenced by multiple factors, including individual, interpersonal, community, organizational, and policy level influences. At the individual level, you have limited knowledge and awareness, so people in rural areas may have limited knowledge about nutrition and the health risks of poor dietary habits, such as consuming high-calorie, low-nutrient foods, and this can be addressed through education programs and can empower individuals to make healthier food choices. In addition, attitudes and beliefs play a role in the nutritional decisions made in some rural and low-income areas. There may be cultural, personal beliefs that favor traditional diets and high-fat, sugar, and processed foods. Health campaigns or programs that promote the benefits of healthier food can encourage healthier eating habits. Then you want to take a look at individual characteristics that play a role in dietary intake, such as sex, age, race, and socioeconomic status. At the interpersonal level, family, friends, and peers significantly influence dietary behaviors. Social networks play a key role in shaping food choices and behaviors, especially in these regions. These interpersonal characteristics include family food security, weight stigma and bullying, available transportation, family socioeconomic status, modeling of behaviors of previous generations, and engagement in school assistant programs. At the community level, this would include access to healthy food, community support systems, and local culture affects nutritional decisions. Specifically, availability of retail stores and farmers markets, infrastructure and public transportation options, accessible health care, and educational resources and community health literacy programs. At the societal level, influences include cultural norms around weight and food, media influences, and food marketing, local agriculture, and government assistance programs like SNAP, TFAP, and WIC. Next, we will look at a few applied interventions to see how theory is used to change this health behavior. This first intervention will address the social cognitive theory. It was a 3-week mindful eating home environment intervention titled Home Sweet Home. The goal was to develop and test the feasibility of a program designed to prevent obesity in parents, grandparents, and guardians of young children. This study, conducted by Knoll et al. In 2016, demonstrated the use of social cognitive theory to create an obesity prevention program for rural families. This study targeted parents, grandparents, and guardians of young children to prevent obesity in future generations. Attempts to build knowledge and self-regulatory skills in parents and grandparents in order to reshape the food brought home and physical activity environments to improve eating and physical activity habits of the participating adults and children. Social cognitive theory was used in the design of this program. Social cognitive theory constructs included behavioral capacity, observational learning, self-control through goal setting and monitoring, reinforcements by setting rewards that improve health rather than lessen health, self-efficacy with building skills and small incremental steps through short-term goal attainment, and the environment with better food availability and accessibility. The table here describes the components of the programs and their associated constructs. Next, we have an intervention that discusses the theory of planned behavior. This was a 12-month cooking skills program in a rural Appalachian food desert. The goal was to determine the attitudes, subjective norms, and perceived behavioral control beliefs that influence class participation. So, this intervention used the theory of planned behavior to guide questions and discussion, and it was conducted at the midpoint of a 12-month cooking program. This table here from the intervention addresses the questions that were asked and the constructs they address. So subjective norms were addressed through family connections and influenced social expectations. So bonding during classes, preparing recipes, and the added anticipation of dishes being brought home to the family. Some mother-daughter pairs attended the cooking classes to bond and to spark interest in healthy eating, and a married couple also used the classes for a date night, noting that their joint participation helped ease their transition to healthier eating at home. Perceived behavioral control involved having the chance to try new foods without worrying about waste, gradually introducing healthy options into family meals, and learning how to use cooking tools. Food waste and cost were significant barriers to individuals' control over healthy cooking at home. The expense of food appeared to be the most important factor influencing their choices. So for those with family members reluctant to try new dishes, the fear of food waste was a concern. The cost of food and the risk of waste made it difficult for many low-income families to experiment with healthier meals. So the opportunity to experiment with new foods and techniques in this class helped to alleviate some of these worries. Having access to food prep tools, boosted confidence in making healthier changes. So while many participants might not have purchased on their own, this likely encouraged their use. Despite challenges with fully adopting new dishes, most participants mentioned that they had successfully started incorporating healthier foods into family meals over time. And one participant shared that they're starting to eat more vegetables, and they used to pick it out of every dish. Opportunities to try simple, affordable recipes at no cost played a crucial role in helping participants turn their intentions into actual behavior changes. So participant attitudes, social norms, and perceived behavioral control were key factors influencing behavior change and therefore directly impacted behavioral intentions. So by identifying these motivators using the theory of planned behavior, these interventions can be more effective. Participants saw the monthly cooking classes as a chance for social interaction, new experiences, accessing resources, and improving their health. So the social norms were primarily shaped by family members and traditional cooking practices. Perceived behavioral control was influenced by the opportunity to try new foods, gaining knowledge to gradually introduce healthier foods into family meals, and improving skills through the use of cooking tools. Lastly, this study applied the health belief model. It was an intervention that included a 2-month-long evaluation to analyze the changes in health beliefs among African American and white church members enrolled in obesity intervention programs. And the goal was to examine health belief changes among overweight and obese adults participating in the Be More intervention. This study was based on the health belief model. As I said previously, self-efficacy was exhibited when pre-intervention participants expressed lack of confidence in reading food labels and an inability to cook healthier at home. After 12 weeks of Be More, post-intervention focus groups voiced an increased confidence in eating and cooking healthy meals for themselves and their families. And they actively shared healthy cooking strategies such as flavoring foods differently, and healthy eating and exercise habits were acquired through Be More. Participants showed frustration in not having time to adopt a healthier lifestyle due to the demands of family and work and not possessing the skills to change eating habits and exercise. One participant blamed the fast food industry for not having affordable healthy food options. After 12 weeks of this program, participants voiced their ability to overcome these challenges through lifestyle modifications. Post-intervention was concerned with keeping the weight off by maintaining exercise and healthy eating. It was determined that Be More successfully inspired churchgoers in 3 states to increase knowledge and practice healthy eating and physical activity habits to prevent and overcome existing medical conditions associated with obesity. So I chose the social cognitive theory as framework for my health intervention because of its approach to behavior change. I think it would be a strong choice because it emphasizes that people must have the knowledge and skills to perform the behavior. It focuses on self-efficacy to boost confidence, and by learning through observation in rural environments where social networks are tight-knit, seeing peers and family and other members of the community adopt these habits can motivate others to do the same. So by using social cognitive theory, I can address both the individual and social factors influencing dietary behavior and create lasting change in these communities. So this strategy would use community role models to implement community-based cooking classes, and each class will provide the participant with a recipe and a grocery list so that the meal can be recreated at home. It would also provide health screenings and feedback to participants, and incentives and rewards shall be provided to motivate participation from community members. So implementation, collaborating with local organizations, adapting to local food culture, and ensuring affordability by focusing on low-cost, easily accessible fresh foods. This will provide resources to help participants budget for healthy eating and leveraging partnerships with local stores or food co-ops to provide discounts. Outcome goals of this intervention would be reduced consumption of high-fat, high-sodium foods and increased intake of fresh, whole foods, improved health outcomes such as lower blood pressure, reduced cholesterol, and better weight management, therefore reducing obesity prevalence in the community, and increased self-efficacy among participants to make healthier food choices and sustain those behaviors long term. So participant surveys before and after the intervention will be used to assess changes in knowledge, attitudes, and behaviors. This will regarding diet. Health screenings to track changes in health outcomes, and community engagement metrics such as attendance at cooking classes or participation in group discussions and potlucks. So this intervention targets individual self-efficacy, social support, observational learning, and community norms, making it well-suited for the needs and challenges of rural Appalachia while promoting lasting dietary changes and reducing the health outcome of obesity. The ethical concerns associated with this intervention would include limited access to resources. So in rural Appalachia, healthy food options like fresh produce are not always accessible. If participants are unable to access these items, it can undermine the effectiveness of the intervention. Financial barriers are also an issue. The intervention is meant to be designed as low cost or in some cases free, but some community members may still find it difficult to afford these healthier options. Resistance to behavior change, so it's inevitable in some cases, especially when participants are unable to sever ties with cultural food traditions and or are skeptical of the benefits associated with healthier diets. Another issue, data collection and privacy. So there are concerns associated with collecting health data, and this can, and especially if the information is shared to the public or not used appropriately. So mistrust of medical fields can make participants wary of sharing personal health information. This intervention also poses a strict emphasis on the individual. So the individual is focused on through cooking skills and food choices, and this could cause the intervention to overlook broader issues, including food deserts, socioeconomic inequities, and limited access to healthcare. The last one, so weight stigma and social pressure. Those partaking in this intervention could feel stigmatized if they are being inadvertently labeled as unhealthy. This could lead to feelings of embarrassment, especially when they're already dealing with multiple other challenges or health concerns. That concludes my presentation. Thank you for your time, and let me know if you have any questions.